Good evening, ladies and gentlemen. It's my proud fortune to welcome you all to the 94th webinar conducted by the Believers Webinars and Clinics Committee. This has been a very successful project being undertaken by Believers Church Medical College. Through all past 94 webinars, where we have invited very efficient people who are stalwarts in their field to speak to us on various topics, educational and other topics. The purpose of the webinar was to be in the community, to keep ourselves together in the community and share ideas of knowledge, ideas of wisdom, ideas of inspiration. I thank our patron, Dr. George Chandi Matitra, the person who conceptualized and who is running this program, Dr. Jacob Jesrun, who is the head of the Department of Pharmacology, all the members of Believers Webinar Committee for taking active interest in continuing this program. I welcome all of you to this extremely fruitful webinar, which is going to be conducted by Dr. Rennie Napoleon, Professor and Head Department of Surgery. When the chance of this webinar came to our department, we were thinking what should be the topic. So Dr. Rennie, who is a visionary, he told us that academic topics are irregular in these webinars. So we should go a mile above it, and we should present something in which not only the wisdom or the knowledge should reach the students, but also the fact that above the wisdom and the knowledge that we gain through daily studies, there is a hand of God which completes everything, every work that we do. And probably this invisible, but this essential part is always forgotten. When you do a successful surgery, when you treat a patient successfully, and when the patient goes back home, the amount of work God has done in treating that patient is most of the times forgotten. So we wanted to bring this fact onto the minds of the students, that whatever work that we do, it is actually God who completes it. Rennie sir always says that what is actually surgery? Surgery is actually augmenting of the healing process. God has designed the healing process. You put an incision on the skin will heal on its own. What we are doing is just making adequate surroundings for the skin to heal. Or the body parts heal by itself. It is not our thing that we do, but it is actually the God's creation, the miracle of the God's creation that actually caused the healing. And we are just augmenters of it. So Rennie sir always teaches us not to be proud of anything we do successfully in surgery, and at the same time we need not be sad, or we need not be lost when we meet failures, because both of the things are not decided by us. It is decided by a power above, which determines how the course of treatment should go. And I'm sure apart from all these descriptions, about Dr. Arpit and Dr. Amy, who have actually resurrected a dilapidated mission hospital which was about to close down, to one of the most advanced secondary care mission hospitals in India. That is a very inspiring story, but that story, I think, should be spoken about in some other instance. Now what they're going to tell us is how in their daily work God fulfills the treatment process. God fills the treatment process and completes the treatment process. And none other than Dr. Arpit and Amy can talk to us more clearly about this topic, because they live and they work in the most undeveloped, or they started working in the most undeveloped hospitals. where probably their hands, their prayers, and God's wisdom were the only investments for the successful treatment of the patients. So I'm sure for all those of you who are listening, this will be a life-changing experience. And it is very rare that the husband and the wife comes together in a program to speak. And by God's grace, we could bring both Arpit sir and Amy ma'am together in this webinar to speak. So may I now hand over the camera and the mic to Dr. Reni sir to welcome the speakers and start the webinar. Thank you.
Thank you, Dr. Reggie. Thank you very much for the kind words. I feel privileged today to be sitting here to talk to and introduce two of some of the greatest youngsters that I have met. One is Dr. Arpit and the other is Dr. Amy. A wonderful couple, blessed by God, and they have demonstrated through their work, their service to the poor and underprivileged, especially they are working in a state where medical care, good medical care, is very rare to come across. They have demonstrated through their faith in God how miracles can occur, how the poor can benefit. They have also demonstrated a good education is also a blessing of God, and not only the education that they have got, they have put it for the poor. They have used it to serve the poorest of poor. If any of us medical students are listening to that, not only you, the seniors, his colleagues, Dr. Arpit and Dr. Amy have demonstrated how to be humble, how to be kind, how to be compassionate, and how to work and pray, and to use work and prayer for the service of humanity. So with this, I feel most humble today. And as well as one part, I'm feeling humbled. On the other side, I'm feeling very proud that I have this opportunity to introduce Dr. Arpit and Dr. Amy to all those on the Zoom meeting right now. Welcome, Dr. Arpit. Welcome, Dr. Amy. I hand over the mic to Dr. Arpit.
Thank you so much, sir. And I don't know what to really say. I must say this very frankly, that all the very kind and sometimes superlative words that were used to describe us are true only in the sense of our calling from God and what He is enabling us to do, actually. Because I am the same as or less than most of you, and we're all the same. We've all had similar upbringings. We've all had the same thoughts. I don't see myself as anything different, but and that's why it's a bit embarrassing for me to hear all these words. But thank you so much, and I just want to say that none of those are about me, because I know who I am. But I'm really grateful that my God has taken me and taken our family to places where we would not have otherwise been. Now, when Renji asked me to do this, I was really uncomfortable, because this is not something we talk about often. It's very easy to tell the story of Madhipura and to say what we're doing there. But this is somewhat more difficult. But I thought, initially, I really tried to say no. But I thought it was a good opportunity for me actually to once again look at the way we live and the way we work, and to thank God in public for what He's doing through our lives. I also want to say that actually, as Renji said, more and more I am very convinced that we are just instruments. So now we pray in our hospital before every surgery and every procedure. That prayer is no longer a matter of routine. It's a desperate cry to God to say, please help this patient. Because any surgeon will know that the most routine of hernias can go drastically wrong, and the most difficult and impossible of major surgeries can go extremely wrong with every possible trouble on the table, but the patient can just go home well miraculously. And for us in Madhepura, it's a daily occurrence. And just in the last 2 weeks, there have been so many of these instances. In fact, now the story is not finished, but there's a lady, Komal Kumari. She's come with extremely high counts, severe sepsis. The family apparently knew that she only had one kidney functioning, but they didn't do anything about it. When she came, her creat was 16. All her electrolytes were haywire. She was immediately intubated and she needed dialysis. Now we've started hemodialysis in our hospital, but our physician is on leave. So me, the surgeon, and my family community physician who's taking care of medicine, the two of us in consultation with a nephrologist and a physician did the dialysis the first time. And nowadays she's had 5 dialysis. She's improved drastically and she's on the road to recovery. Now, I just said that story to say that actually these are everyday things. Every day we are seeing these things, but we hardly stop to thank God for them. And when there's a presentation like this, I began to put things together and I saw that there are so many of these stories which I can share. But before I go on, I'll just tell you where we are. That small black dot is us in North Bihar. And this is Madhepura district. A few stats just to give you an idea. 62% of our population live in multidimensional poverty. In Bihar, there are 26 beds per lakh of population, and Madhepura is less than 5. 75% of the healthcare in these areas is by rural Jola chaps. Now, these are people who will, poke the injection through the clothes, and the main injection that they do give is steroids. I hope you can see my screen and my video. Yes. Renji told me not to make a presentation. So this is more or less the end of my presentation. The rest of it is only going to be videos and pictures. Oh, there's one more. So if you look at the 50 worst districts of India, this is according to the national data from 2015 and 16. You will find that in the previous slide, we have Supal, Araria, Purnia, Bhagalpur, Khagaria, and Saharsa. These are the 6 surrounding districts and Madhepura. So of these 7, 6, that is, 4, Purnia, Saharsa, Araria, and Madhepura are in the worst 25 districts, and 2 more, Khagaria and Supal, come in the worst 50. So 6 out of the 7 are in the worst 50 districts of India. So now with that sort of a statistic, you can imagine how bad the situation is there when it comes to health and family welfare. And in addition to that, we have this huge problem of the caste system. Now, the caste system in India has been designed by the upper castes to keep the money with them. And this group of people who come under this untouchable group, they have been given the term Mahadalits by the government. They are the Moosahars. Moose is rat and Ahar is eat. So their oppression over centuries has been so much that they have actually come to a point where they have rats as one of their staple diets. Now, of course, with the government taking a lot of care for them and the public distribution system working well, it is not very common for them to eat rats, but they live in ghettos in the villages. They are ostracized from society. Their children never go to school, and their only hope is to find themselves a subsistence existence. They don't really have a chance for a future like all of us. For me, working in a place like that always reminds me how blessed I am. We're always talking about how we as doctors deserve something. We deserve a good job, we deserve good salary, we deserve a good perks. But actually speaking, we didn't earn any of that. We can argue that it's because we studied hard and so on and so forth. But actually, the truth is we were born into good families. We were given good intellects. We were given good educational opportunities. And everything that we have has been given to us. So for me, this has been something which I realized at some point in my journey. And from then on, it has become easier and easier for me to be able to look at my life and the life that we live there in Madhipura and the work that we do with a different perspective. And that perspective is a sense of gratitude for all that we've received, and a hope that there is something at least that we can give back for what we've received. So I'm just going to briefly go through a few of these miracles. Ranji said I have half an hour, so I hope that I will be able to stick to that. This lady came to us about 2 weeks ago. She had this huge lump in the abdomen, and we couldn't even examine it properly because it was so huge. The CT scan said that there was a liver lesion and there were 2 separate lesions in the from the ovaries. So we did all her metastatic workup, which all came negative. And I was really scared to do this operation because I knew that if we don't take out everything, including the liver lesion, we're not going to be able to save this lady. But the fact is, this lady did not even come to the hospital by herself. She had been lying in her house waiting to die. Our community health team, we have a community health team that goes village to village and does health camps, does a lot of community work. We are involved in education, we're involved in disaster management and relief, we're involved in agriculture and livelihood, milk cooperatives, farmers groups, vegetable producers groups. We're involved in entrepreneurship, encouraging women to make handicrafts, sell them. We're involved in women and Dalit empowerment. We're involved in school health, a lot of things. There's a huge, vast community work that we do, which is involving in these most depressed areas. And when our team went to the village, they saw this lady lying down in her room, waiting to die, because she'd been like this for 3 years. She'd been to some hospital, spent all her money, and there was nothing more. Her husband had left her and run away with somebody else. She had one child who was being taken care of by the village people, and she was just waiting to die. So she had nothing. So there was no chance that she could go anywhere else. And the only way that we were going to do anything for her was to operate her. So we did, praying. Actually, I would not have done it. I was fortunate to have a good obstetrician with me who just pushed me into going ahead for the operation. The tumor surprisingly came off quite well. Even from the liver, we were able to remove it. She unfortunately had a rebleed after 2 days, so we had to go in again. The liver had the tumor had vascularized from the liver. And when I had closed that off, I think I missed one vessel that had bled. So, but fortunately, we could close that vessel off again. And this was how she left on the day of her discharge. Now, when I look at that tumor and when I think about how we were talking before the operation, we talked to some gynae oncologists who all felt that this might not be the right thing to do. But because she had no other option, we went ahead and did it. And now she's more or less cured. We're still waiting for the biopsy report. This was just 2 weeks ago. But most probably we think it's a fibroid only. And just that it was there for so long that it vascularized everything else. This is the child I operated just 5 days ago. You can see there is a diaphragmatic hernia, the spleen, congenital diaphragmatic hernia, 2 days old, born outside, did not cry at birth for about half an hour, came to the hospital, we resuscitated the baby, and we saw that this baby has a congenital diaphragmatic hernia. Now, as you know, this is a really difficult operation. I mean, the operation per se is not difficult, but the post-op management is extremely difficult. By God's grace, over the last 3 or 4 years, we have been able to enhance our facilities. So we have neonatal ventilators now. We have very good ICU facilities. We have a lot of advanced surgical equipment. And this has been a great blessing because we are now able to provide these surgeries to patients who could not at all afford them otherwise. So we, of course, talked to the patient's relatives, said, why don't you go to a bigger center? But the baby was sick. I mean, not really fit to be transported. And the nearest center is Patna, which is 6.5 hours away, 7 hours away. And even there, the chance of them getting good care is very low because they'd go from hospital to hospital and get just shunted around because everybody wants to see the money. And if there's no money, then the chance of getting treatment is low. It's very difficult, sometimes difficult for me to talk about these things so matter-of-factly, because I know in South India where I grew up, it's so different. But this is the country we live in, and these parts of India are really different. And it's still a bit of a culture shock for me to imagine that we could live in such extreme luxury while others live in such extreme poverty. And even today, the way I live, my house, my all the facilities we have, it's very different from the way these people live. And I really don't know if and how and when we'll be able to start bridging that gap. Anyway, so now the problem for this baby was, and for many of our babies, is the anesthesia. And it so happened that right now, as you know, Amy is in Kerala. So uh, there's no anesthetist. And we have a set of nurse anesthetists who are very competent, but certainly not competent enough to be trusted with the anesthesia of a baby. But there's no option. So we went ahead, did the operation. Uh, by God's grace, the anesthesia was all right. The baby is on the ventilator post-op for about 3 days. We extubated the baby. As of today, the baby is doing well. We've started NG feeds for the baby. This is the post-op X-ray. You can see the diaphragm has come down. There was a hole there about 3 into 4 centimeters. Fortunately, there was a good sac, so I did not have to enter the chest. We pulled the spleen down and pull back the bowel, and yeah, the baby is doing well by God's grace. Now, I say all these things, and I think in no right mind would I have operated a baby like this. I remember about a year ago, we had a baby with a tracheoesophageal fistula, esophageal atresia. And even that, those are all operations which I have not even seen, let alone done. But that is where now I am so blessed, because we have so many facilities to contact people. So at any point of time during an operation, I can call up someone and get some excellent advice. And that's actually how most of our surgeries are done, apart from the general surgery, which I know. I call someone. So if there's a plastic surgery, I'll call a plastic surgeon. If there's a neurosurgery, I'll call a neurosurgeon. If there's a hand surgery, I'll call a hand surgeon. If there's a pediatric surgery, I'll call a pediatric surgeon. And sometimes with live images, we've installed a software which allows us to stream our images from our screen right directly to the phone of another person. So with that, we are able to get extremely good advice. So it's telemedicine at its extreme, I can say. But patients like these get help through the help of people all over the country and the world. This is a very personal story, actually. This is baby Grace. Baby Grace, I still am moved when I think about her story, because it's so personal. And at the same time, it's the story of so many children. And just a small difference could have been the difference between her being alive and her being dead. Her mother had conceived through wedlock, and nobody realized that she was pregnant until her 6th month of pregnancy, when she threw a seizure. Now, in North India, where antenatal care is more or less non-existent in the villages, eclampsia and preeclampsia are very common. And we've actually written up a study on, because of the large number of eclamptics, which has recently got accepted for publication. So eclampsia is a huge problem, and this lady came completely unconscious and throwing seizures every 10-15 minutes. So at that point, of course, the mother's life is the most crucial, and the family, first of all, didn't believe when we told them she was pregnant. And when we finally convinced them, they said, we want this baby dead. So as we usually do, we induced her, and she had quite a rapid delivery. The mother was still ventilated on the ventilator, but the baby came out. Now, when the baby came out, the junior doctor who was there, who took the delivery, he looked at the baby and the baby wasn't breathing, and he said, we'll just leave the baby. But the consultant who was there, who just came, the consultant came just at the time after the baby was born. He said, no, why don't we just resuscitate a little bit and see? So a little bit of resuscitation was done. The baby started breathing, just taking very shallow breaths. And then we decided we'll leave the baby on the head box with oxygen and see what happens. We won't put CPAP, we won't intubate, we won't do any of those aggressive things. But I remember at that time, there was a nurse there who told me that, no, we should try and save this baby. And we did pray. We did pray for that mother and for this baby. The family, of course, was very keen that we don't want the baby. To cut a long story short, this is how she was about 3 months later. I think her weight, if I remember right, was 900 grams or something. but she slowly put on weight. She became fine, and the family left by the third or fourth day. Once the mother was fine, the family left, and this baby was in our hospital. Got to know all of us for about 2 or 3 months, and then we were able to give her to the local child protection committee, and they gave her for adoption. And the adoptive parents who came from somewhere in Bengal, when they came, they took her, and they our team got to meet them, and they said thank you, and they left. So every time we've actually, the name of our nurses hostel, which had just gotten built at that time, is now the Grace Hostel, in remembrance of baby Grace. This is not an uncommon story, actually. The number of times we have babies, 600 grams. We had a baby, I think 686 grams or something, which has survived. Now, you need to remember, we don't have a pediatrician in our hospital. The pediatrics is taken care of by, right now, one of our family physicians or by me, but we have a very good link with a neonatologist from CMC Vellore, and he does regular follow-up of our patients, plus two pediatricians, Dr. Koshi and Dr. George. So we have a lot of help again, but these sort of things are, for me, knowing so little about pediatrics as I do, I know that these are miracles. And especially when I see baby Grace, and to think that she could have been just another statistic of stillbirths. She is now a person with a family and with a future. It's very moving for me. This gentleman came to the hospital unconscious with a creat of 11. He had probably, it was either rickettsia. We think it's rickettsia. He had an illness, and he was in multiple organ dysfunction. Now, at that time, we didn't have hemodialysis, and they, of course, as usual, very poor, didn't know where to go. So then we discussed with physicians, nephrologists. That time I was the only consultant. We didn't have any other consultants. I was alone. So then finally, we said, let's just try peritoneal dialysis. So now, of course, we didn't have the peritoneal dialysis fluid. That has to come from Patna, which wouldn't come that day. It would have come maybe 2 days later, and someone had to go there to buy it. So we actually did peritoneal dialysis with normal saline for about 12 hours till that fluid came. In about 4 days, his creat was down to less than 2, and this is how he left the hospital, with a creat of 0.9. Now, I have never done peritoneal dialysis before, and of course, after that, we started doing it a lot until we got the hemodialysis machine. And I don't think anybody in the world will be able to scientifically prove that normal saline peritoneal dialysis helps. But we gave that, and we saw the patient improve in terms of his potassium, his creat. I don't remember the exact values right now, but until we got the dialysate fluid, he improved, and I think he was on the ventilator for about 3 or 4 days before we extubated him. So for me, as I look at all of these things, as I talk to you, I realize that, in medicine, we are trained in a particular way, to think in a particular way, to believe completely in the value of science. And very often, I mean, especially I see young consultants who will see a patient, and then, because that does not fall within the very narrow defines of the purview of their specialty, will then refer the patient. So I think most of these patients which I have shown you, I should not have been treating, but it so happens that I did. So the one thing that has changed in our hospital, I think, has been that we've really stopped referring patients. We give them the option, of course. If they are well-to-do, if they can go to bigger centers, then they usually go there. They don't come to us. The people we see are people who actually can't go anywhere else. And even if they did go somewhere else, I mean, the number of patients who have been bankrupted, you see the medical system in India, especially for the poor, works completely on out-of-pocket expenses. So when we see a patient, we need to remember that we are not just treating this patient, we are also treating his family, because this whole family is going to be involved in his treatment. If we give them a bill of 10,000 rupees, this person is not going to have 10,000 rupees. he's going to have to borrow it. So up to 20, even 30,000, maybe he could borrow it from his friends and family. But more than that, he's going to have to borrow it from the money lender. Now, what is the rate of interest of in Bihar? It is 10% per month. So that means in a year, we are looking at 120% interest rates. So with 120% interest rates, the interest that they pay is even higher than the principal. So you can imagine how difficult it is for people once they take a loan to ever pay it back. So what do? They then mortgage their land. So what has happened now in all the villages, the moneylenders control all the land. And most of our people are landless laborers. So they work in the moneylenders' field, which used to be their field. And when there's no work, they migrate. 90% of our population migrate for livelihood. I think many of them are there in Kerala. So when we see a patient, we just can't blindly prescribe the tests and the drugs that we're used to. A cancer patient, for example, cancer really needs to be explained to people, because they will spend any amount of money for a cure only to realize at the end that they were never going to be cured in the first place. But people have given them expensive chemotherapy drugs, completely bankrupted them, and put the rest of the family in debt for the next 2 or 3 generations. The system of bonded labor in our villages has become so common that now it is the norm. If you don't have money, you bond yourself to the moneylender until you can pay him back the loan that he gives you. And you might never pay him back, in which case your children become then bonded laborers to him. So for us in Madhepura, it is this is also part of the challenge, and this is also part of the miracle. For me to look at this person and say that we could treat him for, I think he must have paid some 1,000 or 2,000 rupees. Whereas in any center in this country, apart from a government hospital, his bill would have been easily near to 1 lakh. I think that's also a miracle, because we are able to take care of patients without worrying about the cost. I don't have to worry. The belief of all of us in Madhepura is, if we take care of our patients without worrying about the cost, God will worry about the costs. And so far in the last 4 years, when I joined the hospital, there were a lot of financial issues. But so far, I can truly say that we've never had a month that we couldn't pay salary, even in the worst times of COVID. And we've spent a lot of money on infrastructure, which God has been able to provide to us, in spite of the fact that our costs are so low. Our bed charge is 100 rupees per day in the general ward. Our consultation fee is 30 rupees. That is to see a consultant, not a general doctor. Consultant can be seen at 30 rupees. Our rates for cesarean is 5,000 rupees. Operation fees, total cost will come to around 15,000. If you add drugs, maybe around 20,000. So everything is really low. And on top of that, we give a lot of charity. Patients who can't pay, our philosophy is we work based on the paying capacity of the patient. So if a patient can pay 10,000 rupees, he'll get his hernia done in 10,000 rupees. At the same time, if he needs the Whipples, he'll get the Whipples done in 10,000 rupees. So his paying capacity is what determines what we take from him, and not the actual cost of the hospital. And we are experimenting with this design in the belief that God will take care of the cost that we lose. And of course, the numbers need to be large. So all of us have to work a little extra hard, spend a few sleepless nights. But by getting large numbers, so far the economics have played out. And we really believe that they will continue to play out. How much time do I have left? I think, yeah, it's time to stop. I'll quickly wind up. This is a lady who came in pregnant, and you can look at her heart. She was in severe heart failure. She had to go on the ventilator. I think we did a cesarean for her under local. The baby was fine. She was on the ventilator for some time, and then we were able to extubate her, and we sent her home. In about 3 months, she came back, and guess what? She's pregnant again. But this was her X-ray. I don't know. Maybe not 3 months. Might not have been even 3 months. It was just very soon after we had discharged her. How does a heart go from being that big to this small? I don't know. But this is something which I've always looked at and said, I remember we prayed with that patient so much every day. When she was on the ventilator, we were praying that she will somehow survive. This was in the early days when we had just come, and we were really praying that, We had to prove that patients on the ventilator can be extubated. That was a big challenge because many people don't believed, and even now people come and tell us the patient on the ventilator, the patient is already dead. Why are you going on like this? The patient is already dead. So we had to prove that patients could come off the ventilator. So we were really praying that she'll come off, and then she came off, and in a short time, her heart had completely settled down. I'm not going to go into all the stories for these, but just to say that, we have a lot of issues with blood, and there's no blood bank. So often we have patients who come with hemoglobin of 2 grams and 3 grams, and the relatives will not be interested in giving blood. And even to get the blood in the night, we'll have to trouble the blood bank people in the government hospital, and they don't really like to be troubled. So very often, especially if the patient is bleeding, if it's a placenta previa or a abruption with bleeding, we don't look at the hemoglobin, we just take the patient to theater. So many times 2 grams hemoglobin patients somehow have come out of the anesthesia without going into trouble. I don't know how it happens. Somehow just when they're about to arrest, the blood will come. Of course, there have been patients who have died as well, but those are very few. I remember one ruptured ectopic patient, 2 grams hemoglobin. We didn't get blood at all. There was no blood. It was a difficult group also. So we just auto transfused the patient, and the patient was fine. I think her post-op hemoglobin initially was 2 grams, and after that was some 4 grams. And she went home. Ruptured uteruses, so that's the other thing. Sometimes, like now, I'm on leave. So when I was the alone consultant, my junior doctors had to handle things they'd never handled before. So a patient comes with a ruptured uterus. They've got to handle it. They've never seen it before. They've not done it before, but they do it. We pray and we do it. I remember the story of one junior doctor who had the rupture. It was an obstructed labor which had been there for, I think, 7 days, and the head had been stuck for 7 days. So the cervix was completely, on the ultrasound, they could see the cervix was completely gone. So they thought that this is going to be a bad rupture. When they opened, no cervix, the whole lower segment is necrosed off. You cannot close that uterus. So this junior doctor did a cesarean hysterectomy on this patient, having never seen a hysterectomy done before. Just praying, looking at the book and doing. So for me, I remember another story of a time when that time I was a junior doctor and I had a MS consultant with me from Ludhiana, and both of us hadn't done neurosurgery. But a patient came with a bleed. We just did 4 burr holes. The patient was completely unconscious. The blood came out of one of the burr holes, and the patient got up and went home. So I could just go on. There are so many stories. When we were during COVID, the way our oxygen never ran out, we'll be on 1 cylinder left, and just miraculously, suddenly out of the blue, 25 cylinders will land up from Patna. Suddenly out of the blue, some 25 oxygen concentrators will come. We figure out ways to use 3 oxygen concentrators to make high flow oxygen, to piggyback in the oxygen concentrators. Amazing stories. There are so many of them. I could just go on, but I see that I've completed my time. So I'm just going to end with one last story, and then we can maybe have some thoughts from other people. This is a very gory picture, so please, I apologize for that, but it's a true story and it's a very powerful story. This lady came to us with, actually it was a day where I was very tired. I'd been operating, I think, most of the last few days, many nights awake, and I was just dead tired. This patient came from the village, having been assaulted by her husband. He took a machete to her and he cut her on the head, the face, the neck. The other pictures are not there. Neck and the hands. So she had tendon injuries in her hands. She had a neck laceration, large neck laceration, and she had these injuries on her face. Now, my junior doctor saw the patient and he told me about it. I said, send them for a CT scan and ask them to go to another hospital, because we just can't handle here. Go to Siliguri or Patna where they can do the operation. We don't even have a neurosurgeon here. So then after about 2 hours, I think it must have been around 3 or 4 in the morning or 5 in the morning, whatever. Yeah. He called me back and said they've come back, they've got the CT scan, but they can't go anywhere else. So then I was like, oh no, what? He told me there's an injury, there are a lot of injuries, and there's some blood clot in the forehead. So I said, okay, take the patient to theater. I'll come and see. So we brought the patient to theater, and I went, and then we shaved the head, and I saw the brain popping out at me, and I saw that the eye was completely gone, the left eye, and I saw that the facial bones, the whole face had been cut through. The brain was exposed. The base of the skull had been cut through and was exposed from below. The brain was exposed from below, and the patient was on the table. So, and I went and talked to the relatives, and they were saying that we're not going anywhere. Let her die if she has to die. So that was how we began. I contacted a neurosurgeon, and we did a video call with the neurosurgeon on the phone. I contacted a plastic surgeon for the face, the skull bone, which we took out from the skull. Her whole skull bone I took out, and we fashioned that into bones to close the defect in the face. And I talked to a hand surgeon for the tendons of the hand. Amy made a video of this, and I think I'll just share that video, which tells the story. Tony, this is the skull. This is the brain. I will end there. If that's not a miracle, what else is? Praise God, all glory to God. Thank you for this opportunity. May God bless you all.
Thank you, Arpit, for all those miraculous stories, wonderful stories. We can just say we are in awe of you. From the time at 17 when I first met you, During the CMC selection, I had the proud privilege of selecting you to CMC Vellore. I knew all along that there were great things in store for you, for the world, through you. I thank God that you are my foster son. Thank God for Amy. We are proud of all that God is doing through you. Thank you for those beautiful stories. We thank God for you. May God bless you, Amy, and the whole team in the work ahead. Renji.
So thank you, GC sir, respected GC sir, for finding time to come over and attend this Zoom meeting. It just shows how much you care for each and every program. I thank you, sir, sincerely. I also thank Arpit and Dr. Amy for what do I say, for doing excellent work, for being God's gifted children, for magnifying the name of God through your actions. You really motivate people like me and all the students of Believers Church Medical College. We stand motivated by what we have seen and heard today. We give glory to God at this moment that we have come to meet a wonderful couple, and we thank GC sir for guiding you all the way to what you have done today. I hope all his foster children will be watching this and be motivated by you. Your video was simply impressive. You have lived up to the biblical chapter of Matthew. Thank you very much. I'd like to thank Dr. Renji for organizing this Zoom meeting, for motivating us, for showing us that such a wonderful family. And maybe when I visit Bihar, I'd like to meet you both.
Yeah, that would be wonderful. Please do come. There's an open invitation for everybody. Thank you so much for your kind words. Thank you, George uncle, for everything over all the years. I'm so glad that you are just going on and on blessing people. I've heard so much about all that is happening there. Thanks to you. Yeah, thank you so much, sir. Dr. Rennie also for this opportunity.
And I'd also like to just say here, actually, for the anesthesia part, I always call Anita Matthew. Dr. Anita is here. She's the one, I mean, for all this case, even this neurosurgery, the congenital diaphragmatic hernia, everything before the case, I'll call Anita and just, ask her. So even though we are across the country, there's still a connect with the Believers Church, the hospital. I also call Dr. Ashu every once in a while. So yeah, so thank you so much. And thank you for giving us this chance to just speak and share our stories.
Yeah, we'd love to be with you in your ongoing journey. Though we can't be there, you must know that we really value and appreciate your work, and we'd like to do everything possible to help you do even better. Thank God for you. Renji?
Thank you. As we conclude this webinar, it was a blessing to have you both here. And I would also tell to the students that this hospital, Madhipura, is in need of you. And anyone who wants to see these miracles directly, you should contact Dr. Arpit and Dr. Amy. Go there and experience. Never think that Mission Hospital is a place where your work is limited. From what we have seen right now, you should have understood that there is no limit for God's grace in anywhere. If God's grace is there in your hands, no place is a limit for your work. No place is a limit for miracles to happen. So if you feel inspired, you should go to one of these mission hospitals. You should contact Dr. Arpit or Dr. Amy, and you should go and experience these miracles for yourself. Thank you, everyone, for attending this. I should also acknowledge Dr. Abraham Matthew, who is kindly attending this, Dr. Philip Uman, who has come to attend, Dr. Tinu ma'am, who is attending this, our consultants, Dr. Jonas Kurian sir, Dr. Patsy ma'am, and we are very blessed to have a really good audience this evening. I thank each and every one of you. Thank you so much, George and Lisa, for coming for this meeting. We just end the session. We will put the notice for the 95th webinar. This has been a very exciting journey. We are now completing 95 webinars in this series, and soon we will reach the 100th webinar, which will be a celebration, and we all can be proud of this endeavor by Dr. Jacob Jessurat. Thank you one and all. Good evening. Have a good night.
Thank you.
Thanks, Abdul. Thank you.
Thank you. That was absolutely amazing. Thank you, sir. Yeah. Single killer. You're